No. Yeah.
Okay, so now we have Goulda with life communication.
What's up?
Or
All right. So my name is Goulda Prondo. I'm originally from West Virginia, moved up here for the flight job, and living in Casper at the moment. So a little background about me. Oh gosh, I started in your seat 32 years ago as an EMT. Worked my way up, did volunteer, did career EMS and stuff. Moved to the Eastern Panhandle, West Virginia, which is Shepherdstown. It's about an hour 15 from DC, same direction to Baltimore too. Ended up running career EMS there, took a career fire and EMS job down in the city. Loved it, ran the ranks, taught, did a bunch of stuff. And I knew at one point I wanted to be a nurse, but I wasn't like ready to jump out and go do it. Finally hit a point, went into nursing, worked in the ER, worked in ICU. ICU was like my last home. And then I did some travel nursing as well, just to get different experience, different levels of care, see how the rest of the world operated. Got offered a job to do critical care ground transport. It was something new that WVU Medicine was starting up. And what that entails is West Virginia too has B's. They did away with A, so it's basics, paramedics, and then what's called a C3, an IFT paramedic, which they can do certain types of drips, titrations, as well as vents. But if it exceeds their protocols, then what they do is they put a nurse or higher on there to transport those patients. So it's a ground version of a flight crew is what it comes down to. So I did that for about a year. 5-year plan was to move out here to Wyoming, started looking for jobs. Life Flight was open, so I jumped on it. So my 5-year plan kind of sped up. So that's a little bit about me. I'm easy. If you have to go pee, do whatever, you can walk, get out. So I looked over 14 and 16 and they're repetitive. Okay. So I do interact a lot because I'll ask you guys questions. Honestly, there is no wrong answer whatsoever. Okay. You're either in the ballpark or you kind of pass the exit, but we can take another exit and come back. Okay. So you guys tell me about patient assessment. What is an assessment? I don't bite. Only bite on Thursday, so you're good. No, kidding. Just take a shot at it. Okay. All right. Yep. So an easy way to do this really is you've heard of scene size ups, right? Windshield assessments, situational awareness, that type of stuff. So if I come in, I'm immediately sizing up my scene. So if this is a patient's living room, I'm doing a quick scan, I'm looking at my patient, but I'm also seeing what is around me. Do I have medications? Do I have O2 tank? Are they living like a hoarder status? You know, I'm trying to get that quick picture as I'm coming up to the patient. And a habit that I just developed over the years is when I come up, I'm like, hey, my name's Goulda, and I go for a radial. And I start checking a pulse there. That gives me my pulse, my skin. I can also, as I'm sitting there talking, I can look at their neurostatus too. Okay, are they making eye contact with me? Are they talking to me? Are we slurring? What's our work of breathing? So I can get like a quick snapshot of what's happening. So that's how you can break patient assessment down. And pardon my French, it's simple, okay? Just keep everything, don't make it harder than what it is. It's not, okay? So, all right. So what is the difference between a history of a present and a past medical? What was that? Okay, so like, why'd you call 911? And what is your medical problems that you have in the background? Okay, so I called because I've got stomach pain today, but I've got a history of diabetes, heart, you name it, they've got the list. Okay. So again, we were talking about really, this is your scene size up. Do I have family there? Do I see medications? You can also notice too that some family members will want to talk for the patient, and you kind of kindly have to either remove them, have like your partner be like, hey, why don't you go over and get this for me, and kind of get them out. So that way you can start that interaction. And you can too find out if this is like an abuse case, whether it's physical, emotional, sexual, anything of that nature, just kind of the interaction of what's happening there. So I kind of skipped through a lot of these. So tell me about our acronym OPQRST. Oh, okay, crap, sorry. Please tell me this stuff. Just be like, we don't know it. Oh, okay, all right. So onset, when did it start? I don't know if you guys are writing these calls yet. It's like you get this person that likes to call at 3 o'clock in the morning because they've had back pain for 5 years, but all of a sudden they want to go. And they got their luggage and their snacks, and you're like, oh, okay. Provocation. What's provoking it? So if I'm having shortness of breath, is it constant? Is it chronic? Or is it upon exertion? Is it more inhalation? Is it more exhalation? Quality. So we rate things like 1 to 10, right? Is it bad? Is it stabbing? Tell me about it. You want to ask open-ended questions, not closed-in. Because if you say, are you having chest pain? They may like say no, but they could be having chest discomfort or something else to describe that. So I always ask them, like, tell me about what's going on. Make them describe it to me. Quality, region, is it radiating? Do I have pain going from my left shoulder? But if it's my left shoulder, I could be having other organ functions going on as well. Do I have a tearing sensation in my back, but I also I have a pain there, but I have a tearing sensation in my abdomen? That's going to be your AAA. Severity, your 1 to 10. Time, when did it start? Did it start 3 years ago and today it got worse, or did it just now start? So back to the sample. Okay, you guys learned sample, right? Tell me about sample. Sorry. Uh-huh. So an easy way to do an assessment, because I mean, I've been in your guys' shoes. I was trying to follow that template and it just seemed very robotic. Okay. I have a conversation with my patients. Same thing when I was in ICU, bedside and stuff. I'd come in and just start talking to them. And I'm like, hey, what's your name? Hey, I'm Goulda. What's going on? But as I'm talking to them, I'm like, hey, take any medications? You got any dogs? You can quickly slam 2 minutes into 60 seconds. You just kind of have to find what works for you. Okay. I ask them if they take any medications. Are you allergic to any? If they've got a list, I'm thinking of the most critical. What is going to kill them? Do I have something in my kit? If I give them, it will kill them. Okay. And same with when a person presents multiple problems, I'm looking at what's going to kill you first, and I'm going to take care of that. Okay. If you're having trouble breathing, you're tachypnic, you're diaphoretic, you can't speak, one word, I'm worried about your airway. I don't care about your diabetes at the moment. Doesn't mean I don't care. That's not my priority at the moment. Okay. Last, oral intake. Why do you think that's important? Mm-hmm. Could it be something that they ate which is causing the problem? Okay. Um, Events leading up to what happened. What were you doing? If I got back pain, did you fall? Did you get hurt? And as you start poking around, you find out, oh, well, I fell off a 10-foot ladder 5 days ago. Now I've got this problem. Okay. Or no, I wasn't doing anything. I was sitting here, playing video games, whatever. So kids are completely different. Anyone have kids? Okay. How old are your all's kids? Okay. So talking to a 3 is different than a 7-year-old talking to your teammates here and stuff. Okay. My boy's like 21 now. So our conversations have changed over the years. But when you're talking with a little kid, you want to get down to their level. I don't want to stand over top of someone. Why do you think that is? Yeah. And you'll find that too with some adults. You know what I mean? Just get at their eye level, have a conversation. I'm notorious for like sitting down when I was bedside, I'd get in trouble because I'd walk in with a cup of coffee, but it was just, I wanted to build a rapport. Yeah, hey, what's going on? Try to relate to a kid. You got to talk at a kid's level. Don't use big words. Use something that they're going to understand. I let them play with my stuff because when I now have to go do a blood pressure, listen to lungs, they're not scared. I have them help me. Okay. Sometimes parents can escalate the situation. So again, it's just kind of about feeling the vibe, what's going on. Um, hey mom, would you mind going to get this for me? You know what I mean? Just kind of redirect. It can get frustrating, I will be honest, because you're like, you got a really sick kid and you're like, ugh, but you have to be the one controlling everything that's happening. So if you were to get I want to say a child, a preteen that you think that has been sexually assaulted, okay, and you've got family or something there, what do you think you should do or can or cannot do? So the biggest thing is you guys are mandatory reporters. Okay. It is a very uncomfortable position to be in. It's uncomfortable to have to report it. Because I mean, if you walk in, you see a kid and it's like, these bruises, these injuries, things aren't adding up. You're required by law to report it. Now, what you want to do is you want to make that child or that person safe. And what is safe? It's getting them in your unit. Okay, you have got control. You want to keep them safe. You want to reassure them. We don't do in exams. Okay, I know there's people out there like, no, we don't do exams. Okay, that's for a forensic nurse to come in and do stuff like that. If you feel that it would not be safe to transport the parent with the child, then do get law enforcement. Okay, just be like, no, this isn't good. You can meet us. You can try to explain it to them, but if you can't, always get law enforcement. Okay. Um, I'm bringing up those subjects because they do happen. You will run across them and they will challenge you on how you kind of deal with things. All right. So, primary exam, when we start going, we want to observe. We've already done our like scene size up, we're observing. Okay. So, I've already palpated. Sorry if my hands are cold. But I mean, I can start feeling, do I've got a pulse? What's his skin temperature? Is my pulse regular? Is it thready? Is it weak? You can start telling a lot there. If you have a pulse 80 or more, you'll have a radial. If it's 60 or more, you'll have a femoral. If it's 40 or less, or 40 or greater, it'll be up here. Okay. So if I don't have a pulse, my it's obviously below 80. Okay. Um, listen, what are we listening for? If I'm listening to lungs, what am I listening for? Okay. Well, what else? Uh-huh. And what else? Just throw it out there. Do I have equal? Do I have all four lobes? Am I listening in back? Do I hear more like posterior than anterior? Um, do I have inhalation wheezing or exhalation wheezing? Sometimes you can hear stridor and stuff too up in there. There's great YouTube videos out there on listening to lung sounds and just getting kind of familiar with them. I strongly encourage that because they aren't easy. Okay, and especially like if you're in a noisy environment, you're just going to have problems. Okay, and never be afraid to say, I can't hear this, give it to someone else, be like, can you hear? We don't, and in the helicopter, we can't listen to lung sounds. That whole sensory is gone. So for us, like that assessment is very crucial to do with that patient before we load because we don't hear anything after that. But there are ways to kind of see what's going on with your patient. So pediatric, we've all messed with like kids, talked with kids. And it's just kind of having them, first of all, you got to gauge your child. Okay. Some children are very articulate, some are very shy, some have like speech impediments. You'll deal with autism. Okay, you'll have some that are on the spectrum too. So it's really trying to figure out who's my little friend here that I got to talk to. And sometimes it's best having a family member or a caregiver kind of help communicate. Okay, big thing too, we'll hit with autism and anyone on the spectrum, lights and sirens do escalate. Loud noises do escalate. So if you ever get called out and you've got, someone's wound up or they're like, man, this guy's a real ass, they're acting out, they're blah, blah, blah. Just slow things down, turn off the lights, turn off the sirens, kind of like decrease the noise, because there's a lot of people that do have sensory issues that we're not aware of, and we can cause more problems, or we can treat what we think it is when it's actually not that. All right, so body systems. Have you guys listened to lung sounds yet? Have you done any of that? No? Oh, yeah. It's going to be exciting for you guys. All right. So you're all sitting here like looking at me like, oh, God, you're crazy. All right. So the disposable stethoscopes are trash. I'm just going to be honest with you. Like the yellow ones, you can't hear. They always put them in isolation rooms. It's just, I always take in my own stuff, wipe it off when I come back. There's different makes and models out there. Whether you buy your own, you'll figure out what works best for you. They're great now. They come amplified, which I'm getting old. I'll probably have to go that route. So talking about respiratory conditions, we'll hit COPDers real quick, okay? I'm just going to be hitting a bunch of all over the place. So a COPDer, do they drive off of oxygen or what's our other gas? Huh? Uh-huh. So which one does that brain drive off of?
You think it's a, I can hear you guys listening.
The opposite. So our brains, we don't have it. We're driving off oxygen, okay? So we want our SpO2, our pulse ox to read 93 or higher. Okay, your COPDers, they live 86, 88, 90. We got to stop there. So that's one of the things. If you come in, someone's got trouble breathing, you're like, hey, what kind of history you have? You're like, I'm COPD. You slap on the pulse ox, you're like, oh man, they're 86. Slap that non-rebreather. What you're going to do is you're going to shut their drive to breathe off. Okay, because they don't regulate that way. So throw them on 2 liters, cap it at 3. Okay, because that's where they live. 86, 88, 90. You'll be lucky with some to get 90. Okay, so again, that's part of your assessment, your questioning, your sample questions with your patient. Asthma, do they take medications? Do they have a rescue inhaler? Have they taken their rescue inhaler? How many times? These are the types of things. Is it helping? Rescue inhalers, it will make them real tacky. Okay, just think about your inhaling speed in a sense. Okay, so their heart rate's going to be higher, but is it helping? If it's not helping, then we're going to have to start taking it to that next level. All right. So respiratory, again, it's what is my mental status? What do you think happens to a person when they're real tachypnic? They're breathing real fast. They can panic. What else? Confusion. Yeah, so there's some of the like big things you need to look for. So why do you think that is? If I'm over here, why do you think that happens? Again, there's no wrong answers. I want you, you'll hear critical thinking, okay? But this is how we learn to critically think. So if I'm breathing in real heavy, am I getting enough oxygen in? No. So if I can't get oxygen in, am I blowing? What am I blowing off when I exhale? So I'm going to end up blowing a lot off, right? But I'm not getting enough back in. So think about like I build a fire and my fire starts going out. If I add more wood, my fire gets bigger, right? But if I start taking things away, it's going to just go down. Well, when you have someone that's extremely tachypnic, they're breathing hard, they will get tired of breathing. Their body's like, I'm done. We're out. And then you end up having a respiratory arrest. Chest wall. You see it more in kids. You'll see a lot of, we call like retractions and things, and you'll see them really working up in here. But when I'm looking at my patient, how is my patient breathing? Do I have good chest rise and fall? Do I have more abdominal breathing? Do I have some paradoxal movement going on here? Like my chest, we're going the opposite directions. When you palpate too, I'm going to touch you, is you're sitting there feeling and stuff. Do I have crepitus? Crepitus is Rice Krispies, that crackly feeling, and that's air in the tissues. Okay, so someone could be like, oh yeah, I fell, I landed on my side and it was a couple days ago and it hurts. Well, now that I got Rice Krispies, I've got a fractured rib. Okay, pulse ox. Pulse ox, all of your equipment is a tool. Just remember that it is a tool. If I look over and my pulse ox says 82, it's cold outside, but my skin color looks great. I don't have any work of breathing. You know what I mean? It's like, I got to look at my patient. Is my patient saying the same thing that my pulse ox is saying? If it's not, then all right, why? Are my fingers cold? Do I have nail polish on? Do I have some type of peripheral disease to where I'm not getting enough oxygen because of my medical history? Is it your environment? One of the things that I've learned moving out here is like negative 15 degrees. If we pull our vent and our IV tubing out of the helicopter just to transport to the hospital, all of that freezes. So your IV tubing freezes, your vent circuit, everything freezes. So again, it's like, what element is my patient in? Do I have any edema? What is edema? Okay, so if it's swelling of the legs, is that going to be a left or a right heart? Just take a while. Okay, so I do really bad drawings. Do we have a Sharpie? Yeah, cool. Cool. Oh, it does say permanent. Good call. Oh, okay. All right. So we won't go over. So this is going to be a heart. It's going to be a circle. Okay. So I have 4 chambers, right? Yeah. What sits up on the top? Atrium or ventricles? Uh-huh. Okay. So I got my ventricles down here. And if this is me standing, which one's the left, which one's the right? Okay. So I have my right and I have my left. Same for here, okay? We're not going to go in depth on any of this, okay? So then you got a bunch of valves. So your atrium fills, comes down here, ventricles shoot it out. So we either go to the lungs or we end up going to the body. Okay, so you had said left, right? Or did you say right? So the way I always try to remember is left is lungs. Okay, so if I've got crackles, I've got a lot of congestion, fluid, your CHFers, we're going to have left side. If you've got peripheral edema, we've got right. Okay, it's pushing through the body. So back to edema. There you go. Have you heard of pitting edema? Okay, so pitting edema, if you're closer, so you're my guinea pig, is I'm going to be like down at the ankles, I'm going to be pushing in, and I'm going to push and release. Does it pit? How deep does it pit? Sometimes people will do what's called third spacing. They're so full of fluid in their tissues that their skin will start weeping. Okay, so that's part of your assessment. So if I'm sitting there looking and I've got pedal edema down here, okay, I want to take a little gander at your legs there. Do we have diabetic legs going on as well? Do we have PAD, which is peripheral artery disease? And you get that like purplish black looking color of people's legs. Are they scaly, that alligator looking skin? Fever. So does everyone's temperature run 98.7? No. Mine's 97.2. If I hit 98, I start feeling feverish. Okay. So again, does my patient look feverish? Are we sweating? Are we hot? Are we flushed? But we always get a temp on our patients and we always get a glucose because that'll tell us a lot too what's happening. If I do a glucose, if I got an altered patient or someone who's confused, I check your glucose real quick. I just need maybe to fix your sugar. You know, give you a little sugar there, see how you do in about 15 minutes. If you're good, then now we know what's going on. All right, so basic, simple way to remember the heart. Your heart's a pump. Anyone in the fire department? All right, cool. Yeah, I did fire too. I loved it. So your heart's a pump. All your vessels, everything, that's your hose, or those are like your pipes in your house. Okay, if my pump isn't working, am I filling my pipes? Now, if my pump gets real sluggish, like, you drop something down in there and it's your pump's just bogging down, do you think I'm able to move what fluids through there? No, it's just going to be starting to be stagnant and stuff, okay? So this is talking about patient in shock or with a vascular problem. So I looked up here earlier, and here are your 4 stages of shock. So obstructive, is there something in the way? Am I obstructing flow? Okay. Distributed, that's through your body. Okay, so like your septic patients, you've heard of septic shock, they get distributive shock, which then can also go into cardiogenic. With your sepsis patients and stuff, you can have someone who's septic, but when we hit septic shock, you start watching the vital signs shift the other way. We've got fevers, we got confused, and again, sepsis, the body is dry. Okay, so everything starts failing. Your kidneys, liver, heart, everything's like, okay, yeah, we're done. Cardiogenic, something's happened with my pump. Okay, I can lose a lot of volume, hypovolemia. And if I lose volume, I can push myself into cardiogenic shock. So if you roll up on a car wreck, you've got profuse bleeding. You've heard of your ABCs, but we got to do our HABCs. We got to stop that bleeding. And you'll have a lot of distractors, okay? Heads bleed like nothing. I mean, it's just amazing how much they bleed. But you need to figure out, what is my main source? Where is this coming from? You have to fix that. That will kill you faster than some of your traumas, like your multi-systems. Is I got to stop that hemorrhage. All right, so let's skedaddle through that real quick. So we've hit back to our OPQRST. If someone's saying, man, I've just got this, I got this pain right here. All right, well, tell me about your pain. On a scale of 1 to 10. 10 feels like you're going to die. 1's like, it's kind of there. But is it radiating? Is it crushing? Radiating, am I going in my arm? Am I going in my back? Am I going up in my jaw, my neck? Women present different than men. Okay. So those are you kind of need to hit a little bit of everything up in there. Like, tell me about what's happening. When did this start? Does something make it worse? Does something make it better? People can have history of angina, which is just kind of an angry heart. Okay. Heart's a little pissed off. They have their nitro, they take their nitro, we're good to go. Other people are like, man, I've been sick, I just haven't been feeling well, something's not right, it feels heavy. They'll have different ways to describe their cardiac event. Okay, so the biggest thing is your heart's a muscle, right? But that muscle, when it dies, it doesn't fix itself, it's dead. So slap some O2 on, even if they're at 98%, put 2 liters of oxygen on. We want oxygen getting to that heart, okay? Again, we talked about the characteristics, the discomfort. Do you have a cardiac problem? That'll tell us too. It's like, okay, I've had like 6 MIs and I've got 8 stents. Oh, okay. Does it feel like your previous MIs? So if they've already had a previous, ask them if it feels like your times before. Oh, let me go back. So we've gone through our pulse, our blood pressure. You guys are going to be learning vital signs. I was listening earlier. Every stage of life has different parameters of vital signs. But when you hook them up to a monitor, I'm going to tell you like a key number to look for. And that is, back to the permanent. So, you have so this is the ICU part of me coming out. So you have your systolic, you have your diastolic, and then you have what's called your MAP, okay? Every protocol state, my PCGs, I have different parameters on these here. What is a low? What is a high? What do I need to treat? What do I not need to treat? I'm worried about this. So I want a MAP greater than 65. So your organs, in order to function, get oxygen, needs to have a MAP greater than 65. So if you're in the back of the ambulance and you got them on the monitor and, okay, I'm like 90/50, but my patient looks good, my MAP's in the 70s, we're good. That could be their baseline for all I know. And that's something you ask too. What's your blood pressure normally run? Mine's like 100/60. So it's, it varies per person. But this right here that's going to be a determining factor. We won't go into the calculation for that. But anyway, MAP, always remember your MAP. JVD, what is jugular vein distension? What do you think it is? Yep. Yep. So if I end up having cardiac, so if we're left or we're right, okay, but either way, we're going to keep this very basic here. I've got some type of strain here, and when I lay that patient's head of the bed around 30 degrees, I'm going to look for JVD. Are my veins distending? So veins have, which direction do they go in your body? Back to the heart. Okay. So have you guys ever been outside all day, you're standing all day, and then all of a sudden it's like your legs are a little more swollen than normal? Well, valves. Do we have valves in our veins and arteries? So here's our little artery. Here's our little vein. So things go down here, but we need movement to bring fluid back up. Okay, that's why if you're standing around for a long time and then all of a sudden you're like, man, my legs are swollen or my hands are swollen because you've kept them low, it's because we aren't moving. We need to be moving. So if I have jugular vein distension, when I end up moving that head, if I'm going from flat to 30 and I see it, I've got pooling. Okay, it's like my blood is not returning, my blood is pooling. So this is, again, we're just kind of hitting the surface on a few things. Not always with cardiac. I mean, you'll see it with cardiac, but if you've got some other form of shock happening with your patient, you're going to start seeing shock parameters with your vital signs. Okay, that's why really learn your vital signs, get comfortable with them, because you can. So studies have shown, evidence-based studies have shown that a person who has a cardiac arrest was leading up to it 3 days prior to. So cardiac arrest in a hospital, that should never happen. Okay, never is a big, strong word. Why should it not happen? Because we've got that patient monitored. Okay, and if we're paying attention to our monitor and our vital signs, we can start seeing that trend before they're going to code. Okay, now, you have that 1%, 2% out there that, yeah, we go. We can't prevent that. But for the most of the part, we're trending days before that event ever happens. So, I mean, you could have someone that's having a silent MI, that's got cardiogenic shock, that's now led to hypovolemic. okay, and we're not moving. So we're pulling. You can see it in some traumas too. Breathing. So have you guys heard of tripod breathing? Okay, if I walk in and I see someone like this and I can hear them before I see them, we're moving. Okay, so on a basic level, you need to think of, can I stay and play or do I need to load and go? That's going to be a load and go for you. Okay, slap them on some oxygen, get them to the hospital because they're going to be able to do medications and things that you guys can't do yet. Okay. So we'll get through some of this here. So neurostatus, if I'm talking to someone, what I'm looking for, I'm looking at their eyes. Are they looking at me? I'm looking at what their eyeballs are doing. There's a astigmatism is where like the eyes will twitch. Are my eyes twitching? Are my pupils equal? Are they reactive to the environment of which I'm in? And you can do a very quick, just be like, hey, as opposed to like me taking an LED light and shining it in someone's eyeball. Okay. I'm looking at their tongue. As they're talking to me, is my tongue midline? Is my tongue slurring? And I'll ask them a question to whatever it is. It's like, oh, if I see dogs, I'm like, oh, tell me about your dogs. People will smile when they're talking about their animals or their kids. Is my smile? Do I have an equal smile? Am I drooped? So those are quick things that I'm looking for. And you can do that in your 60-second conversation with your patient. And then two, it's as I'm standing here, my partner's doing stuff. I'm like, hey, squeeze my hands. Why do I want them to squeeze my hands? So are my grips equal? Are they strong? Some people be like, oh man, I got a shoulder injury, so I'm a little, okay, well, that's your baseline. So I'm going to start trending now off baseline. And then as I'm down here, checking for pedal edema and stuff, I'm checking for pulses. I'll have them like wiggle their feet. So you can do things very quick. And that'll give you a quick baseline of where your patient is. So however long your transport is, you can trend. Is my patient getting better? Is my patient getting worse? We stay in the same. Stroke scale, you guys are going to go over that. Okay. You want me to bypass that?
That's up to you. I mean, if you,
You guys use
Okay.
Cincinnati?
Yeah.
Okay. So there's like numerous different stroke scales out there. I haven't used Cincinnati for a long time. I use NIH. They're all pretty much the same thing. Okay. It's just the layer of how many questions you're asking the person and you're observing. And that rate, it's good if you go in for a possible stroke or a hypertensive emergency. Someone's complaining of a really bad headache, get that stroke assessment real quick. Okay. And then if they hit your guidelines for stroke, then you can call a stroke alert to the hospital. And what that does is it activates the team. And the faster you can do that, the faster you can start treating with TPA or TNK. Pretty much the same med, just a little different length of action there. All right, cool. If your patient's up walking around, look at their gait. A gait is, how am I walking? I mean, are they sliding? You know what I mean? Do we have a shuffle? Do they already have a bad hip? So we got kind of a little wobble there. Same with the knee, things of that nature. And then part of your vital signs too is you can do orthostatics with your patient. So I can check your blood pressure here, but then, you know, we can stand up. Like if we want to stand up and get to the cot, stand up. How do you feel? Still have a headache? You still dizzy? Check your blood pressure again. And then when the patient's down, laying, you can check. But it's really laying, sitting, standing. All right. Go through some of these here. All right, so diabetes, if you come in and I've got someone altered and it smells like alcohol in their breath, are you going to think it's alcohol or are you going to think it's something else? Huh? You speak loud, yeah. It could be, but remember, you guys are now going to be clinicians, okay? So we're trying to rule things out. So if I come in, my patient's altered, kind of smells like alcohol, I'm going to check your blood sugar. Because DKA, we get diabetic ketoacidosis, and it gets a very fruity smell, and it'll smell like alcohol. Okay. Every glucometer is set up a little different. Typical high is set at like 600. So if you hit high, we're over 600. So I'd get a quick figure stick. If my blood sugar is normal range, then okay, we've checked that box, we've ruled that out. Also, too, are they on insulin? Do they have an insulin pump? Have they been sick? If they've been sick, have you been eating? Some people won't eat and take their meds. Some people won't eat and not take their meds. So if I'm not putting fuel in my body and I'm taking my insulin, what do you think is going to happen? We're going to drop. If I'm not doing any of it, what do you think is going to happen? If I'm not putting medication in to help control what I'm not eating, we can go either way depending on the person. Okay, we could either bottom out depending on how many days, or we could be at the high end. GI. So if someone's like, oh man, I've got this pain down here, and they keep pointing to the right, and you're like, ooh, appendix. So then we go through like our assessment. You'll learn about the different like kerning signs and throwing our legs up and checking all that good stuff. Or have you had any diarrhea? If you've had diarrhea, what's it look like? That's the nurse coming out. We want to know what your poop is, okay? How long have you had it? Have you been drinking? Because if we've all been sick before, we've all had diarrhea before, it all stinks, right? And you get dehydrated. Okay, so those are some of the things too. If their abdomen is hard, it's distended, it's rigid, were we involved in some type of trauma which has caused that, or do we have a bowel blockage? All which goes to surgery. So with the abdomen, we kind of do things a little different in the belly. We're going to look, we're going to listen, then we're going to palpate. Okay, because if I start palpating and then I go to listen, whatever gas is in there, it's going to be moving around. It's going to be really aggressive. But you want to listen. They tell you like 5 minutes for each quadrant. We'll leave it at that. Okay. I mean, you can tell if someone's hyperactive, hypoactive, or normoactive. Okay. I don't know if anyone wants someone standing over them for 20 minutes. I wouldn't want it. You know what I mean? I'm just telling you how it goes. Vomiting. How long have you been vomiting? What are you vomiting? What does it look like? If I've got green bile, do I have dark blood, coffee grounds, which would be a GI bleed? I would have an upper, but if it's also that same color, I've got a lower GI. Do I have bright red blood? People who are bulimic end up developing esophageal varices, which will kill them. They can start coughing, they can start vomiting, and it's going to be a bright red blood. And depending on how big those varices are, how many are there, if they herniate and rupture, it's all going down here, and you've got a serious situation there. Bowel movements. I know it's going to be awkward to ask it, but do you have regular bowel movements? How often are you going? Okay, because if someone's like, oh, I haven't gone in a couple weeks, and they're having belly pain, and their abdomen's distended, okay, well, we've got a blockage somewhere. Again, back to looking at our abdomen. I remember I had this patient come up in the ICU, and it was this little old guy. Oh man, it fired all of us up. He's altered level, he's septic, ends up going septic shock. We ended up coding him, got him back, blah, blah, blah. So anytime when a patient comes into the ICU, we do a skin assessment. That everyone laughs. We're very thorough on what everything's there. If we see anything, we take a picture and it gets put in your chart, because then we start trending. Did you develop this under our care, or did you come in with it? Okay. So this gentleman had this, it was about that wide, about 2 inches, all the way around here, and it was bruising. And we're like, this guy lives in an assisted nursing home. He's not driving. So we called the nursing home. I was charged that day, and I'm like, hey, can you tell me what's going on? And they're like, oh, well, yeah, those are heparin shots. Yeah, these aren't heparin shots. Full story. Thanks, guys. So got a hold of EMS, and I'm like, hey, where did you find this guy? What's the story here? What happened? They're like, well, we found him in his chair, and it's the chair with like the locking table. So the table's locked in. He has a gate belt around him. This was a call mid-morning, and he was face down in his dinner. So he had been there overnight. So that's a trauma injury now from him. So because we've got this information, we got the EMS report, they reported, we had to report. So again, that's back to your assessment, is looking at your patient. Okay. If you go out on a motor vehicle wreck, airbags did not deploy, but they say they're restrained, we want to look for belt marks. Okay, because a lot of these injuries can end up manifesting a couple days later. Allergic reaction. So back to like last oral intake, right? Anyone allergic to foods? Melons. Any melon? All right. I got some family members that are allergic to kiwi. Ended up having a smoothie. Didn't know kiwi was in there, and they were in the presence. They were deployed at the time, but they were in the presence of a nurse. And ended up getting shot up because it was like those couple sips. It was like I can't breathe. Now we're in anaphylactic shock, and ended up getting slammed with epi and everything else. So again, it's what did you eat? What were you exposed to? Were you outside? Are you working in any plants? Did you change your detergent? Clothes, okay? You can see rashes, you can see itching, you can see blisters, you can see swelling of the lips. If they have a known allergy to something, do you have an EpiPen? Did you use your EpiPen? Sometimes people will use them incorrectly. I've seen it done in training too, where they go to shoot it in the leg and shoot themselves in the thumb, and it hurts. I've done it, so I can tell you it's not pleasant. So those are questions that you would ask there for them. Okay, we're talking about our exposure. So there's numerous different types of exposures out there. You can have your inhalation, you can have your chemical, you can have your radiation exposure. So again, it's assessing your patient. What were you in? What am I seeing? Do I have burns? Chlorine, has anyone ever dealt with a chlorine spill, leak, exposure? Okay, so chlorine is a gas. And what it does is it comes in, it burns you. And then with that burning, you start filling up with fluid and you drown. Where you will see chlorine is like your pools. Walmart has chlorine. We've had chlorine exposures at Walmart where they ended up busting a bunch of like pool supplies and stuff. People are coming out, trouble breathing, and it's literally we're stripping you in the parking lot, we're flushing you because now I'm bringing that exposure in my controlled environment, which means now I'm exposed. Pesticides are wicked. Pesticide buyers are really bad. Like a, I think you have Menards. I'm still trying to learn what Wyoming has compared to West Virginia, so be patient with me. So we have like a Tractor Supply and stuff like that, okay? Well, you're going to have your chemicals, you're going to have your pesticides and things. So if there is a fire there, you are going to have an inhalation injury. So again, it's just knowing your environment, what's in your town, what can be possible hazards, and think about like if I'm responding to that call at that location, what could my patient have been exposed to and could I be exposed to it? All right. We've hit a lot of this here. Medical diseases. So our musculoskeletal exams. Does someone have cerebral palsy? Do they have MS? Do they have ALS? Okay, things of that nature. Also, too, depending on what type of toxins you're exposed to, will cause musculoskeletal and neuro issues as well. Um, um, all right, so have you guys learned the DCAP BTLS acronym?
Oh, I was gonna say, I don't know.
All right, you shook your head, yes. What is it? Let's just say it. Yep. Oh, oh, oh. Cool. Mhm.
L.
Yes. All right, cool. So those are all things I'm looking for. If I have someone impaled, can I remove that object? All right, so what do we do? Okay, so let's say it's, I'll give you this example. This is years ago. 2-lane road, middle of the night, got hit out for a single vehicle motor vehicle accident. So we're driving out and there's just debris everywhere. There's like trees down. We're like, huh. So we got to stop, pack mules, grab all of our stuff, and go hiking up in. And it was 2 teenagers, both drunk, ended up driving a little too fast, missed a turn, went up the embankment, took out a split rail fence, and ended up coming to a stop. So the passenger had the split rail section impaled through the seat. The driver was impaled here. It snapped off, and his bicep was laying beside him. So he's the first we could get out. So we kind of take his bicep, put it in a little bag, get him, move him out. Well, the next one, we ended up having to take a sawzall and cut sections. So we had to, was an extricate, we had to extract him from the vehicle. And then we had to backboard him on a side because we couldn't lay him flat. So that's an example of an impalement. And it won't fit in your ambulance, okay? Like if you had rebar and stuff, you got to cool it before you cut it, okay? Because that's going to get hot. It's going to end up burning. So just those types of things is think about, again, it's going to be like, oh my God, you're going to be excited, but then you're going to be like, oh, but it's all about kind of stepping back, taking a deep breath. You're in control. If you lose control of the scene, everything else spirals. Okay. It was really cool that night because it was HealthNet back home. We had a 60 by 60 LZ, and both of them landed right there. And they had the time taking off, but they were Vietnam pilots too, so they were really good at what they did. The one boy died, the one that was impaled, and the other boy ended up losing his arm. Yes. Yes, it was. Yes, it was impressive because it was like the hotel Holiday Inn was here. You had a fence line, and trees, and we were all like, "Oh my God, are they going to do it?" And they did. They came in, and you could hear them talking to each other, and they got it down. And it was coordinating on speed and everything, trying to take off so they didn't hit. It was like, wow. It's like military pilots. You can't beat them at all. um, all right, so there's a word in here. Your instructors will probably kill me, but I'm going to strongly encourage you not to ever give a report and say my diagnosis. Okay, never use diagnosis. Mid-levels and higher can only diagnose. Okay, I saw that. I was like, oh God, please don't use that word. You get in trouble. So what do we do then? If we're not diagnosing, I'm assessing my patient. So I want a really good, thorough assessment. And based on my findings is what I'm going to tell the nurse. So what was your name again? I can't remember. Bradley. So Bradley's med surg, but let's say he works in the ER. You float down there, right? So I'm coming in and I'm giving Bradley my handoff here, my report, and be like, hey, this is what I got. This is what I found. Kind of steer him in the way of what I think may be happening, but it's going to be up to the doctor to determine what happens. Okay. And sometimes, I mean, you got like a 2-minute transport, so you're not going to get a real good thorough. So back to the different approaches. We're going to just, we've gone through a lot of this here. So worst case scenario, again, worst case scenario is what is going to kill you first? Okay, I would precept in the ICU and I get these little young nurses. No one's had field experience before, so they don't have the kind of that background coming in. And you've got 15 drips running, you've got a vent running, we've got dialysis coming in. I mean, like everything shutting down. And it's like, all right, let's step back and look. What is going to kill the person first? And I don't want to say it's a hard concept to wrap your head around, but it can be challenging, is if you're going to figure out what's going to kill them first and we treat that, something else is going to happen down the road. Okay, that's the nature of the beast, because the body's trying to compensate, it's trying to work. But you start chiseling away at the layers. So it's the same thing with my assessment. When I come in, do I have something life-threatening that I need to manage right now, or do I have a few minutes that I can stay and play before I load and go? A lot of assessment work, I'm going to be honest with you guys, you're going to have to practice with yourselves, not by yourself, with a partner, with a family member, kids, practice on your kids. Okay. Develop your own routine. Everyone's got their own routine. It's like I flew double nurse yesterday, but we usually fly nurse medic. Okay. So they train us at the same level, but there's only a few different skills that separate me from a medic. Okay. And that's really the thing. We're both doing stuff, we're both communicating. My partner may see something that I totally missed, or vice versa. But the biggest thing is communication. You guys really got to talk with each other when you're on a scene. Talk it out loud. Hey, this is what I'm seeing. This is what I got. What do you think? And just, because there will be times you will forget a step. You will forget things. We're humans. We get tired. But really practice. Really just go through and start practicing those things. Get your routine. I have a particular way I do things. My partner has a particular way, but it hasn't failed me yet because I know where I need to go back and troubleshoot. It was the same thing when I would do bedside. I'd walk in my room and I always did my scene size up. I'd look right at my patient, I'd look at my monitor, and I'd look at my drips. Are my pressors running low? What do I need to quickly change over before I make contact with you? If they're on a vent, I'm looking at my vent. Are they compliant with my vent? Compliant means they're not fighting it. Okay. But that's my routine. I never deviated. That's just what I did, because then I could go back and troubleshoot what's happening. Right. We've gone through. So don't mind me as I'm like, again, we're not doing our diagnosis. That's going to be labs. That's going to be your diagnostic test. Again, it's your assessment. Some of the best EMTs I've ever worked with, actually even better than some medics, no offense, guys, came down to an assessment. Okay. And it's being able to paint that picture to that next level of care and being able to, oh God, I need ALS intercept now. And I'm calling in my medic being like, this is what I got. This is what I think's, happening. This is what I need. And boom. And then they can go from there. Same thing when you roll into an ER. You guys, when you run an EMS call, does fire department chase you, or do they come out on certain?
Our fire department responds to 7 criteria.
Okay.
Seizure.
Okay, cool. Cool. So if it hits that 7, one of those 7 criteria, put that extra person in the back for you or throw them up front to drive, because you may need that extra hand in the back. Okay, never be afraid to say, I don't know. That is okay. I respect that to more than anything. If you say, man, I don't know what's going on, cool, let's figure it out together. But don't come in with an attitude of, I'm holier than thou, I'm God. You will get humbled very quickly, and it's not a fun experience. You guys want to take a break or? Yeah. Yeah. All right.
Do you want to take a break?
I've got my stuff here. I did. Thank you.
Give me a message, please.
Need to look at that book.
Is your email? Okay. Oh. Send you an invoice and the link to pay.
I'm gonna steal this book real quick.
Then what's that, or?
No, it's the it's because it was. It said it was about it anymore. It said it was about it, and it's like, what are you doing with this?
16. I saw something in it.
Is there a Douglas Fire come out? You don't have a Dave Brown Douglas Fire.org?
I said, no, I did.
Oh, no, you do. You do. You do have a little. Have a. No, you have a big writer, Douglas Fire. You don't have one to discuss those people that are on for years?
Cool people.
I have.
Well, then why you guys keep doing it?
Can't believe you come in here. I didn't ask you. Yeah. Okay. Come again? In English? At the freaking ambulance house, it's cold over there too. I'm with you.
You're cold. I'm like sweating.
Yeah,
It's cold.
I go to work, I wear a t-shirt, pants, three shirts,
Nice, that cold.
and a coat. Literally, I'm free every day. Well, hold on
They're not
yourself.
that cold. They're not that cold. She has, when it's super cold out, she puts on, she has these yellow overalls, or overalls, and she looks like a, yeah, they're orange with camo, like up the sides, and looks like an inmate though.
It's awesome.
Sam,
Which side am I on?
no,
Oh,
like
her.
the inmate or
Yeah.
when you come up on the scene.
Right.
Yep.
Stuff. Thinking towards diagnosis. Because of, because they went back to saying, you know, as an EMT, you're gonna look at this patient who's got a right ankle fracture
Yeah.
of the lower leg, and you have to say, they might have a broken leg.
Yeah.
It's obvious they have a broken leg.
Exactly.
Now, you're making the diagnosis, but what I like is the book kind of has a drawn out.
Yeah, I was
And-
looking through explaining the different things. I was like, oh,
It is hard because I went through it in 2000. They pushed that you never diagnosed.
I remember like got into nursing, and my preceptor, she was like the old school 30-year, and she beat that into my head. And she's like, there's a way you can steer them, but we can't claim it as such. And she's like, we get in trouble big time. And I was like, oh. But then I started noticing too, and I was like, yeah, it makes sense. That's why I was like, to say, hey, this is what I got. And you all go figure it out.
That's what we always tell them, too,
Yeah.
Even at paramedic. Like, this is what we got.
Yep.
You know, this is what I think it is.
Roll
Yeah.
out.
Yeah.
Yeah.
Right.
So is that your unit up there?
Huh?
Was that your unit that was?
Yeah, that's,
Oh.
no, that's my RTI unit. That was the last class I trained. in.
Oh, okay.
Or I trained, no, it wasn't the last class. My last class I trained was actually overseas.
Okay, cool.
We just got that.
Excellent. Oh, excellent. Yeah, thank you.
So,
My wallet. How long do you go over?
We were going over 9 months.
Okay.
So,
Yeah.
that's my last one. So
Is
I
it?
retired.
Oh, congratulations. How long were you in?
It didn't shear off. It
Good.
fell out.
It, I mean.
Yeah, door
The
broke
second
it.
you open it, go on.
Mm.
I was gonna say, two or three people came in before it broke.
Yeah,
So,
one came in right before I walked up to the door and grabbed
I
it.
can do that.
All of a sudden I grabbed it and I go nowhere. Like, they don't like me, they lock me.
yeah, we saw you coming.
Yeah, hurry, lock the door.
Well, now.
Don't leave the house.
It won't lock.
Well, why don't we
Oh,
go hammer, thinking bolt in real quick?
I didn't unlock.
Yeah, I didn't. Cause I pushed it up last night.
I mean,
Oh,
yes,
funny you should mention that.
yeah.
You're like, no offense. Girl, I'm not taking it because listen. We have our assistant fire chief is an EMT, but he doesn't work as an EMT. And he has saved my baby twice. So,
Or it's fresh EMT and my partner. We became good friends, but my partner had anger management problems. So we were going to a church and it was reported chest pain, supplemental comes in, working cardiac arrest. Cool. But I'd worked with a bunch of other medics and stuff, and it's like we kind of share the loads. We had the combi tubes, blah, blah, blah. So I go and grab the bags, and he's like, that is an ALS bag, and that's out of your scope of practice. I was like, cool. I see where this is going to go today. And I'm like, you're going to learn the hard way tonight, buddy. So we go in, and he's like, I need this, this, this. And I'm like, it's ALS. I can't touch it. Got the combi tube. I can do compressions. And he was like, whoa. But I'm like, this is going to be your teaching moment. He learned. We became good friends after that moment, but it was like, dude, we're in a 6x6 box back here.
not the time to do
Yeah.
this.
Oh, that's good. Just one.
Just- Oh, I'm spicy, but I ain't prepared for them. I was telling her, JJ's the one with the heart. She's so sweet. Jim is even keel, keeps everybody cool, calm, collected. Real hard to piss off. And then welcome.
I always have to start the disclaimer. I don't mean to sound like an ass. Yeah, I'm the same.
I can be if I need to. Takes a lot to get Jim mad. Me, not so much.
Really quick, on Friday, we're gonna have 2 sessions to study. They'll be at the hospital boardroom at 1 o'clock, then 5:30 in the cafeteria. if anyone wants to.
Listen. Not very nice.
You can order dinner while we study
From the hospital?
from the hospital.
Nice.
It's not going to my cabin.
Well, if you guys are all right, we'll go ahead and start. I don't want to keep you here long. I know you guys have like a lot of long nights and stuff. You can stand, you can wander, you can do whatever. I'm not going to pull the PowerPoint up for 16. 16 is reassessment. Tell me, what is reassessment? Okay, why are we doing that? Okay, but what else? Mhm. Yep. Yeah. Correct. So what is going to be your 5-minute patient? Your 5 minute?
Oh, no, my critical.
I was about to say, dear
Yeah.
God, bro. Yeah, so your critical, your traumas, you want every 5. Okay, 15. How long are your all's transports typically? What's a bread and butter run for you guys? 5, 10 minutes. So you get pretty much your first set. If you have given nitro or something, or you've done an intervention, I just encourage you to grab one more set of blood pressure, set of vitals before you go in the door. Because as they're backing in or pulling in, pop it in real quick, get it out of the way. So assessment, I'm going to use, what is your name?
Daryl.
Hi, Daryl. I'm going to use you as guinea pig. Okay. So we're just going to slide over, roll up here. Oh, you can get your chair.
Oh, no,
Yeah.
it's this one. By all means, get into my ambulance.
Have a seat in the airway seat. You're fine. Sign here. So again, we're at home. Are you at home? Where are you?
Right now, in fact, family.
Well, we haven't got there yet. Do you want to be home or are you? Okay, we're home. So I come in and I'm like, this is me doing my thing. Okay, this is my routine. Again, you all develop your own, but this is what I'm hitting and how I'm hitting it, and determining, do I need to stay or do I need to load? So I come in, I'm looking around, checking things out. I'm like, hey man, what's up? My name's Goulda. How are you?
Good.
And I want to get down to his level. Okay, I don't like people towering over me, especially when they're like really big and they're like, "Rah." Doesn't make the person feel comfortable. You want to build a rapport very quickly, and you will be amazed at what patients will tell EMS and not tell nurses, and vice versa. So you've got to build a rapport very quick. So I'm like, hey man, what's going on? How are you?
Good. You?
Why'd you call?
I don't know what I call.
Okay, let me just stand next to you and be your host. Brief.
When to start?
30 minutes ago.
So I'm pulling out my stethoscope. I'm listening to her, and I'm going to ask, does anything make it better or worse?
No,
Do you have any lung problems? Any allergies?
celery.
Celery? Do you have any celery?
Nope.
It gives me the shits. I'm sorry, I'm just kidding. You take any meds for anything?
Partisan.
Okay. Did you take it today?
I did.
All right. So how's that going?
It's okay.
All right. So I'm just going to be sitting here having a conversation. I'm going to be listening to her breath sounds. She's looking down, but I'm going to try to look at her.
I was trying to be Daryl.
Oh, okay. Hey, Daryl. You have a very nice voice. So what is cardizem? All right, there we go. So we either have a heart medicine, we got a lung medicine, we got a neuro medicine, we got a GI medicine. Okay, you will learn your medications as you go. I, again, encourage you to kind of know your medications too, because that will kind of help you kind of steer what's happening there. So I'm going to ask her, have you been controlled? Have you had any cardiac problems, any chest pain, discomfort, anything of that nature?
That's cardio.
Okay.
Medicinal.
Medicinally? All right. Any casts or stents or? Okay, so I already know we have a cardiac problem. She's been cardioverted. She's having trouble breathing. Can cardiac cause trouble breathing? It can. Okay, so in the back of my mind, I'm thinking, okay, I've either got a cardiac leading to this or I've got two separate things going on. So I've got her on the pulse ox. I'm going to look at my pulse ox. What is it saying? Do you guys run BLS or ALS or?
We do ALS.
Okay.
Usually it's a medic and an EMT.
Okay.
and A, So. yeah.
So you can be hooking them up to the monitor. Okay. Over time, kind of get to know your rhythms too. What looks bad, what looks good. Okay. We'll keep things simple. What needs defibrillated, or where are we going to code the person? Okay. Just know your critical life-threatening rhythms. Get them hooked up, get the blood pressure cuff on, cycle of blood pressure. All right. I can do all that very quickly here. And then based upon what I see, I may have to say, hey man, this is going to be yours. What do you need from me? Okay, so you're going to figure out, am I going to have a BLS patient or an ALS patient? Okay, if you're running a BLS crew, your 2 minutes, I'm still just going to get you in the back of the ambulance because they can do things for you at the hospital that I can't do. Okay, it's the same thing whenever we do a scene flight and we jump in the back of an ambulance. When we get back, we still take our equipment because we got to move it to our stuff. Okay, not everyone has the same monitors. It's just we got to transfer stuff over. But I look over and whoever's the primary caregiver, whether it's a medic or a basic, I'm like, hey, what's going on? So I'm having them give me a report. What did they find? Whether they were just there for 30 seconds or an hour. And then I'm looking at my patient, and then I'm starting to connect my equipment up to them. Okay. If they don't have an IV, we get an IV established, or I start delegating tasks because I'm doing something else. Okay. So we try to minimize our time on the ground as well. Okay. So it's, again, back to the assessment. I've had some phenomenal assessments by EMTs in the state. I'm like, man, this is awesome. I mean, they've got this list, and I'm like, can I take a picture of that? Because it's like I'm listening. Some things I write down, or I'll just take a snapshot. Then that way I have their report sheet with me, and then I can trend off of that. So that's kind of the thing there. Again, figure out what flow is going to work for you on how you approach a patient, how you assess a patient. But as I'm talking, I'm looking at my neurostatus too. He's able to answer my questions appropriately. I'm looking at his face. We don't have any drooping. She's telling me, I'm speaking for my buddy here, you know, we got breathing problems. It doesn't hurt to throw anyone on 2 liters. If in doubt, slap them on 2 liters, okay? Because if you're worried that it's going to be a cardiac or something, I would rather someone be proactive than reactive or just be like, oh, I just didn't do it. Okay, O2 is not going to hurt anyone. And then go from there. If they've got medications, I'm kind of, okay, I don't take people's medications unless we've got a shopping bag full. If we got a shopping, I am not writing those down. It's going to take time away from patient care. I'll just take them, hand them over, here you go. But back to medications and things, it's, if they're telling me they're on something and they hand me a pill and I look at when it's filled, what was the quantity and how many I have there, things aren't adding up. That can also steer me into what's happening here. Okay, you see that unfortunately with people that have chronic injuries, okay, they're going to be popping their pain pills because after a while you just develop a tolerance, so you keep taking more. Some people can't afford meds, so they have someone else's meds. Okay, we've all heard of polypharmacy. So if I take a shopping bag of 50 bottles of pills, and my patient, I always say, like, they're trash. It's like, we've got breathing problems, we've got heart problems, we've got everything going on. It's really good as a bedside nurse is to start pulling pharmacy in and saying, hey, look, I think we're overdosing this patient in beta blockers or whatever else. You'll see that a lot with the elderly. They, you know, they still have problems and they keep throwing more meds at them, but they're not adjusting. They're just giving them more. So yeah, that's just a real quick thing. I get my baseline and then I trend off of that. If I've got someone that's got some type of neuro deficit or a gait problem, I'll ask, have you had a history of a TIA or a stroke? Do you have like a frozen shoulder? You know what I mean? I'll ask because I want to know, is that their baseline? Because if it is, then that's not a red flag for me. If you're on scene and it's a stroke, notify that stroke alert. If you've got a STEMI, notify that STEMI. Door to STEMI time. What that means is my patient has to be on the table, the team scrubbed in, ready to go in 90 minutes. It's not you hitting the ER door at 90 minutes. They have to be ready to go. So it's critical as being able to identify. Okay, so your protocol is 120. Stick with your protocols, okay? Okay. Okay, so Cool. So whatever your time is, that means they have to be on the table. Okay. So it's critical that you come in and you're like, okay, slap them on the monitor. This is what we got. Call it, go. You can do everything else en route.
Yeah, sorry.
Oh, go ahead.
The cool thing is if you are with a partner that is having a STEMI, you don't even take that patient off the cot. We see a STEMI on our monitor, we go into the trauma room, and the room's open. They get treated for that cardiac event, and then we're already out the door. We never move the patient at all. So it is literally.
Yeah. So what they do is like, soon as they hit the ED, they either load with heparin or Brilinta, typically Brilinta, and they'll still have heparin and stuff going there. So they load them, and then they're going straight to cath lab. Okay, same with your stroke. It's activating that stroke team. So whether you have neuro here or you need to do a tele-neuro, they're getting those players involved. Back to the medication, whether it's TPA or TNK, you have a window. And follow your protocols, follow your PCGs, but it has to be administered within a window, and you'll have criteria. So that's one thing, is really know certain protocols going in, because that's going to make or break your patient getting the treatment that they need. Do you guys have any questions for me? I'm not going to keep you long. Assessment's really hands-on. I mean, you got to buddy up with someone, you got to practice with someone, you've got to manually go through these things. Okay. Your skills check-offs, you have in there the benchmarks that pay attention to those when you go for your skills too. Okay. Know those, practice those, live and breathe those.
I love that you said that. Because from day one, you say, this is the most important tool in your toolbox.
It is.
To know them from top to bottom. So to have an outsider come in, are you guys for the exact same thing the three of us have?
It's true. It's people be like, well, that's just a basic thing. Well, I'm telling you, I don't care what level of care. If you can't manage the basics, you can't manage your patient. Okay, it's ABC. All those things have to happen. If I don't have an airway, I'm not breathing, I'm not circulating. You know what I mean? That is first out of the gate. So yeah, just practice that, get comfortable with it. But do you guys have any questions, concerns, hate, discontent for me? Yes. No. So, okay, so there's a bunch of trauma classes. Like once you're done with this, you can take a bunch of trauma classes. Okay, so in the trauma certification world is they move H to the top of A, and that is your hemorrhage. Okay, if I'm hemorrhaging, I've got to stop it. Because if I start losing massive amounts of volume very quickly, and it could be in a matter of a couple minutes, we're not going to be able to fix anything else. Whether it's slap a tourniquet on, pack it, then I can move on to my A's. But again, you're going to be running with a partner. Okay, so that's something that we always pregame in flight. So the way that we get dispatched in flight, we get very minimal information, because there's an industry standard. It's called, they don't want you to be pressured to fly. Okay, so we will get a location. Where is it? Whether it's a scene, we may get like coordinates for a scene, or we may get an inner facility from like Douglas to Banner, and that's it. The pilot goes through, checks whether, can we fly? Do we need to go around or whatever, accepts it. And then when they accept it, then our crew phones, our supplemental comes down to the patient's age, the patient's weight, any drips, an event, and a diagnosis. That's it. We don't know anything else about the patient. So in a sense, we're flying blind, a little more blind than you guys in EMS. Because in EMS, you can get supplemental going down the road. Okay, we don't. Because that's how people crash, is what it comes down to. It's like, weather can be shit, but we've got a really trash, pediatric. We want to help that pediatric, but it's not safe. And that's where accidents have happened. So what we do is then we get in. So like medic sits left, nurse sits right. The medic, the way our 407 is, the pram is right here and the medic sits here. And then we've got the vent, the monitor, the nurse, there's an aft seat, and then the pilot. And what we do is we start talking, what could this be? And we run every possible scenario we can think of. And then we'll reference our PCGs. And it's great because our PCGs are on an app. And I mean, a person can memorize so much stuff, but it's nice to cognitively offload. You know, you want to memorize certain things, but there's others. It's like, let me get back and reference this real quick. Carry cheat cards for yourselves. Okay. We all have, they're stuffed in our pockets everywhere. So then we do is we go through, we get our vent settings. So we have our age, and we have our weight. So we always prepare for the worst. So then we start calculating our vent settings. We start looking at medications. What's our starting? What's our max? Are we going to run weight-based, non-weight-based? So we have all of that laid out there. So then when we make patient contact, it's like, okay, well, we can check that one off, or we can check, you know what I mean? It's like, okay, it's not this, it's not this. And then, but we already have all of our stuff. And then we can, it's more of like a time management type thing. But the way we work too is we have to do a back check, whatever that is. My partner, if my partner's a medic, if my partner's a nurse, and I say, hey, you know, I want to go straight to cardine, and they're like, no, I want to do labetalol. Well, we'll talk it out. Why do we want to go this way? But if my partner does not agree with me, we do not go with my game plan. Both people have to agree. Okay. So that's kind of my advice for you all, is when you're running with a partner and stuff, kind of pregame your call. You know, do like a little pre-play in there. What could it be? This is what you're dispatched to. I remember, oh my God, it was one time, it was out in Marion County, it was out in the boondocks. We get dispatched for a medical. Okay. Very vague, medical. Roll up a farm drive, 2-story white farmhouse. We go in. We have no other information. So we're like, hey, EMS. We're walking through. And as we walk down the long hall, made a right, shotgun. Just like went right past us. And we're like, oh, no. Go out, get back in the ambulance. We're like, scene's not safe, call PD, we're moving out. So lesson learned is just because you're dispatched for something does not necessarily mean that's what you're going to find. Okay. Back to your assessment too, never corner yourself in a room, position yourself for a way out. Okay, I never corner myself. Same thing at bedside. I never positioned myself to where I could not get out. Because there will be a time you will run into that combative patient and you don't want to be stuck where you don't have a way out. So that's part of like your scene size up too, is and it goes back to firefighting. Okay, just because I go inside alpha, but if alpha gets caught or, you know, closed off, what's going to be my next point of egress there? Okay, same thing in the back of an ambulance. I never wear lanyards around my neck. Breakaways don't break away when they need to break away. So I don't like things up here because once you've been choked a couple times, it's not a pleasant experience. But again, it's like safetying your patient, safetying your scene. If people carry weapons, make sure you don't have a weapon on your patient. If you have a lockbox, that's awesome. Put it in a lockbox, leave it at home, leave it with the cops, leave it with someone. We had a hikers, this is right when I started here, and it was reported, it was a hunter, let me rephrase that. It was a hunter chest pain. And we're like, okay, so we're 45 minutes into flight. It's 2.5 for the ground to come. So we're like circling and we're like, do you have coordinates? And they're like, well, it's over by this ranch. And we're like, where's this ranch? Well, this ranch is 60,000 acres. It can be anywhere in this ranch. So we just hovered and hovered. And then probably for about a half hour. And then they were like, oh, there's people down here. Cool. So we land and there's a guy and a boy. And they're like, yeah, he's over that hill. And we're like, oh my God. So we're like grabbing all of our stuff, hiking up over a hill. No, it wasn't that hill. It was like 4 hills later, 6 miles later of hiking, we made patient contact. And this patient, I mean, we were just like, the guy's having legit chest pains. he's got a right bundle branch block, and it's like, okay, we're diaphoretic, and we're like, dude, we have nothing to carry you out. Can you walk? And he's like, yeah. So our pilot, I don't want to say we got in trouble because, well, let me just finish the story. So anyway, he's finding a closer LZ. So he broke free from us, circled around, found a closer LZ. So it was within our mom, our 100 by 100, everything, terrain's good, but we had a hot load because of the altitude of which we're sitting in now, the weight of the crew, the weight of the patient. So it's one of those things, it's like, are we going to leave someone behind? Are we going to be able to now lift off? Because we're sitting at 11,000 feet. And it's not that challenging when it's cold, but it's more challenging when it's warm. Okay, because we can't carry that much fuel when weight becomes a big factor. So we were able to lift off. It was close, but we got him back safely. Everything was there. So back to some people try to say we were doing search and rescue. We don't do search and rescue. We weren't. They didn't know where the guy was. You know what I mean? So it'd be like the same thing in EMS. I've done it in EMS before. You're like driving out this country road, and then all of a sudden you're jumping on a four-wheeler because you can't get your ambulance in, and then you're putting them on a backboard on the back of a four-wheeler trying to get them out. So it's one of those things. It's like, did you violate a policy? No. Did you safely get to the patient, treat them? Was your crew safe? Yes. Okay, so I don't know why I just told you all these random stories there, but yeah, it's what it comes down to. It's just because you're dispatched for this, it may mean you're hiking 6 miles in. And then, you're looking and this is all you've got on you, and you've got your big war bag, your monitor, your drugs, and it's like, bro, we got to walk. It's like, we can sit down with our little knives and start making like splints with trees and things and cutting our flight suits and making stuff, but it's like, kind of need some help here. But again, it's just, what do you go into? You don't always know the full story.
What did we learn on Monday?
Yes. All right. So any other questions or anything? I don't want you guys to stay late. Oh, well, okay, then. Sorry.
We're gonna do assessment.
Cool.
Whenever you're done.
Yeah, I'm done with lecture. Yep, we're good. All right. Oh, yeah, you're welcome.
You're welcome to stay.
Cool. I'm here for whatever. All right, sweet.
We would love for you. You need to go.
I'll